Welcome, everyone. Big round of applause for Kiah Williams. My name is Antje Kirschner. I would like to welcome you all to today's event. Big welcome to those who are also joining online. And we're excited to have you, and belated Happy New Year to everyone. The Biodesign Health Equity Innovation Discussion Series explores different perspectives in using innovation to narrow down inequity. And we would like to welcome and thank you, our partners, the Stanford Center for Innovation for Global Health, the Bay Area Global Health Alliance, and the Stanford Global Health Graduate Network for joining us and helping us bring these events to life. I mentioned the housekeeping items already. Please turn down your phones, stay on mute, and type your questions in the Q&A. In Zoom, we will try and get to as many as we can after the presentation. Now to today's speaker, Kiah Williams. The title of her talk is Leveraging Nonprofit Business Models in the Healthcare Sector for Impact. And she's sharing the lessons she's learned over more than a decade at SIRUM. But I want to ask you a hypothetical question first. Who here in the room has heard of food waste? Yeah, I'm not surprised that almost all the hands are going up. Who here in the room has heard about medicine waste or medication waste? Okay, that's nice. It's not nice, the subject, because it is almost 11 billion of surplus medicine that is going to waste each year in the US. And that is where SIRUM comes in. It is a tech for good nonprofit company focusing on expanding the access to life-saving medications for families in need. The team does this by collecting unexpired, unopened medication from nursing homes and pharmacies in their network and redistributes those to their community partners. So we will hear from Kiah, one of the co-founders at SIRUM, how the team does that. Prior to SIRUM, Kiah led negotiations for the Clinton Foundation American Heart Association to create the Alliance Healthcare Initiative, and she brings a very deep experience in effective public-private partnerships, program evaluation, and how to build community from her time organizing at the NAACP. She's been recognized for her work as a Forbes 30 Under 30 social entrepreneur, America's 50th most influential women by Marie Claire, and Silicon Valley Business Journal 40 Under 40. Please help me welcome Kiah, a Stanford graduate as well. Thank you for coming.
Thank you. Hello. Right. Hello. Thank you, everyone.
All right.
Hi.
Hello. Nice to have you.
Great to be here. All right. Okay, awesome. Hi, everyone. Thank you so much for having me. I am Kiah, one of the co-founders of SIRUM. So yeah, just to start out a little bit about problem setting here and setting the scene. So SIRUM, we are a nonprofit, also known like a non-governmental organization. We are a 501, it's classified as a 501c3 nonprofit organization in the United States, meaning we're a charity, and we're also a tech company. And our goal is to tackle essentially two huge injustices that the United States in particular has. One is that about 50 million people, about 1 in 4 working age adults in the US, don't take their medications because they cost too much. And these are prescribed by, their healthcare provider, their doctor, nurse practitioner, physician assistant, whomever. Like their healthcare provider is saying, you need to take these medications. And in the United States, we do not have the most cost-effective or affordable healthcare system. And so this is how many people kind of go without the medications they need to stay healthy. And those medication costs are too high. While at the same time, this is actually a real photo actually of meds in giant kind of medical incinerator bins sitting and waiting to be destroyed. And so these are all unopened, unexpired medications, 11 billion with a B dollars of medicine going to waste. And so this just doesn't make sense in an era where we can literally track a food delivery coming to us within 20 minutes and see what street they are on, for conveniences, why we can't actually make sure people get the medicine that they need and meds aren't just flushed, incinerated, put in a landfill, etc. And so SIRUM was basically founded on a pretty simple premise. How do we make sure no medication goes to waste? And so we connect that surplus with with communities and the people who need them. And so essentially our technology we've built is end-to-end for medicine donation. So we actually get it from like a donor facility that has surplus unused medication, predominantly places like pharmacies and nursing homes, and donate those medicines instead of destroying it. We then use technology to help match that donation, like where can it be donated? Who needs that medicine? Where are they located? In the US, this is quite regulatorily complex, meaning there's both federal laws to consider, but also state by state and regional laws that we all have to comply with. And so that because we're using technology, we essentially can create a system that makes sure that the right medicine goes to the right place and get it to the hands of patients. Then on the distribution side, we're working with a set of nonprofit clinics, nonprofit pharmacies to get it into the hands of patients. And so we're essentially trying to make medicine donation or recycling, upcycling, whatever you want to call it, the norm, basically creating a secondary marketplace for good for medications that are, again, perfectly good, perfectly usable, not expired, sealed, all of these good things. And so our earlier years, and that kind of like when we first started these, my co-founders, Adam and George, it was really about us just kind of prototyping and really understanding what is the problem that we're trying to solve. So our early you'll see kind of our like very early platforms on mobile and on desktop. One of our very early lessons, for example, was around, like, we tried to build a lot of really interesting and fancy tech to basically help organizations to track the meds that they were donating. And like scan it in, see what you can donate, see where you can donate, see more details about the organizations that you were donating to. And what was really fascinating as we continued to just do more and more need finding is we essentially realized like this bottom left corner became, in the beginning, one of the most impactful things that we could do, which was actually like designing a box for people to put medications in. And so you'll see in the center photo, this is actually one of our very first nursing homes who donated, the director of nursing there packing away her medications. What we realized is like the medicine donors, for example, they did not need a very fancy technology solution. The core was really, these meds were going to go into a medical waste incinerator. They were going to get thrown into a hazmat bag. We needed to have an alternative for them, which was, in our case, basically just making a recycling box. And that became like the way that we were really able to get things moving on that supply side, was really deeply understanding after, being in our own little world of trying to figure out, hey, what features do we need on this online platform? It was really, how do we make it as easy as possible for these organizations to donate instead of destroying their medicines? And for example, in early days, like when we went to go visit some of these facilities, realizing that some of them, I still remember one of the first facilities I went to, the area that they had medications stored, there were no computers. So building a fancy like desktop or mobile, like a web app or mobile app, was going to be a very hard push to get them to use because they're literally in a room with a giant trash bag. And so if instead we could give them a recycling bin, that would be way more impactful for them. And then on the distribution side, what we realized was, like as we were connecting community clinics, community pharmacies, that was actually where a lot of our technology prowess and like where our technology ability could really help. Was a lot of folks, like the inventory management system was really pretty standardized, pretty routine, and didn't really allow for donation in a meaningful way. And so what I mean by that is it was really interesting because like when I first went into and started visiting a lot of the like nonprofit pharmacies and clinics that we started to partner with, what we realized, like they were like, oh yeah, we do a system called visual inventorying. And I thought, for example, I was like, oh, visual inventory, that sounds like really cool. That sounds really high tech. And if you've ever been into a local like retail pharmacy, you'll notice kind of all the bottles are kind of, lined up. They're in alphabetical order, one by one. What I came to realize was like visual inventorying is literally like if there is a spot on the shelf where there is no bottle, you go to that spot and that's what you order. So it's literally just visually looking at a shelf and looking at what is missing. So what we really realized was that our ability and like where we could have a lot of impact on the technology side, we thought it was going to be originally on the medicine donation side. What it turned out to be was actually on the distribution side, like helping these organizations collect and get medicine in and get it inventoried. Because the big challenge was if you're purchasing medicine, right? Like you're purchasing from a wholesaler, you're putting in an inventory order. When it comes in, a very classic way of doing it was someone having a purchase order and checking off a box saying, yes, we've received it, and then logging it into their inventory system. The thing that became quite challenging is donation. It, to some extent, is a magic bin of you don't know what you're going to get. And so we had to have a way where they could really input inventory where they didn't know what was coming, or someone didn't sum it up correctly. If they did, even if they sent like a very detailed record of donation, you had to have a way to reconcile it. And so you'll kind of see on the bottom right, we actually started moving towards a system in which the receiving organizations could actually easily input inventory, see what they were getting, and help them make some decisions around keeping that item and then generating a live inventory. And so we basically ended up building technology to help other organizations understand their own inventory. But what was interesting, because so we did this for quite a few organizations, we did this at the state level, we did this for a lot of like what we call the safety net, which is a very broad and very wonky term to say, what are the organizations, who are the people who are doing good, who are either charging no money to their patients or very, very minimal fees, or having kind of sliding scale solutions where basically their primary metric was around impact and helping patients, not necessarily profit. And they were really, had a very strong program in that. And so that's essentially in the US what we call the safety net. And that's a combination of, it could be government entities like local, county, or municipalities. It could be standalone, again, nonprofit organizations. So it could actually be anything from a very small free clinic who works in a church basement twice a month with volunteer doctors and nurses, all the way up to a fully functioning federally qualified health center, which receives federal and state level ongoing funding to operate, and provide primary care services, OB-GYN, pediatrics, et cetera, like basically to try to stand up a primary care clinic in a lower income community. So that entire ecosystem was essentially who we were building for. But what we learned at some point was, as we were building these programs and building technology for some of these organizations, they were very hyper local. Most healthcare in the United States is incredibly hyper local. I mean, like 2-mile, 5-mile radius. So it really became a question of scale for us, of like, how do we continue to scale to meet that bigger issue, and that to address that larger need for patients where 1 in 4 working age adults are skipping medication. When we think about supply and demand side, we were getting really good at getting a lot of supply. The question became on the demand side, are we going to have a program like put a donation program to receive on site sort and get medications out to patients to like hundreds or thousands of these smaller organizations, especially when literally sometimes they were operating just a few days a week. Essentially, we came up with an issue of scale. When we think about supply and demand sided marketplace, we're a two-sided marketplace. On the demand side, our partners, like, we just could not scale them fast enough to really meet the need. And so what we did, our current model, and what we essentially did was we vertically integrated. We actually launched our own warehouse and integrated pharmacy model. It was an idea that we thought, like, hey, if we can use the existing infrastructure of the safety net of free clinics, government, et cetera, like, let's do that and just be, very classic, very Bay Area, very Silicon Valley, like software as service. And said, okay, like, it looks like in order to get the scale that we want to see, we will need to do some vertical integration. The opportunity came for us because of actually some policy changes in the state of Georgia. And we essentially launched this new facility stocked with donated medication, and the advantage of what we were able to create basically at the size and scale that we had gotten to through the software as service, and now being big enough and having enough volume on the medicine donation side, is we could actually stand up a full service pharmacy that would deliver, in this instance, while healthcare itself, like going to the doctor, having someone take your temperature, blood pressure, all of those things, that maybe needs to be in person. Do you need to be seen in person to refill your blood pressure medication? Probably not. And honestly, it's another potential chore for someone to have to make another errand, another trip, which has all other kinds of ramifications for people who are lower income. And so we essentially were able to stand up a fully functioning pharmacy that also delivers to people's home. And so thus we could have a greater reach than that 2 to 5 mile radius of people just in the neighborhood, and instead be able to basically reach an entire state and even multiple states and more regions. And so we essentially wanted to say, like, how could we reimagine an efficient pharmacy operation using technology, with the backbone being this surplus donated medication? And so that's included things like custom inventory management systems based on chaotic storage, which enables us to basically just kind of scan it all in, throw it in a box, it's on the shelf, and we only go, kind of do more organization when it's actually called for. And last year, we actually did a pretty big, large installation and automation to even reduce like manual data entry, and instead use some robotics, machine vision, and AI to say, actually, can we get to the point where we take a giant box of donated medications, dump it onto a conveyor, take photos of everything, scan it all in, and actually have a live inventory generate for that, and able to gain a greater than 10x efficiency within that. And so within the past few years, we've been able to basically become the biggest charitable pharmacy in the country. And our pharmacy, Good Pill, has distributed over 1 million 30-day prescriptions worth over $100 million across 3 states. And so that's a kind of what we do, kind of the evolved business model there. And, the thing I want to spend a little bit, and we'll talk a little bit more about this and would love questions here. SIRUM is a not-for-profit organization. It's a 501c3 charitable organization. But our goal is financial sustainability. And so it's really important to note that not-for-profit, non-governmental organization, kind of whatever your frame of reference is to the idea that our primary metric is community impact, not profit. Nonprofit doesn't necessarily mean no revenue. There are absolutely entities where it does not make sense to generate revenue. We believe that there is an opportunity here for revenue, and in particular for us to look at earned revenue to cover our operating expenses. And so we're essentially able to monetize a bit on both the supply and the demand side. So on the donor side, undercutting destruction prices. So where are organizations otherwise paying for a regulated destruction process, can we actually reduce what they're paying by offering them this opportunity to recycle, to donate? And then on the end side, kind of that's on the supply side where we're able to really generate some earned revenue. And then there's also, of course, on the demand side to our end patients. Folks want to contribute in this country towards their healthcare. It's just that the costs are just simply unrealistically high. So the answer that we came up with essentially is, can we allow people to have transparent, flat, affordable pricing? And so for the vast majority of generics, that ends up being $2 for a 30-day supply of medicine. And that helps offset some of our costs for that. So our plan essentially is to continue to, increase revenue, earned revenue from supply side and demand side to just generate more revenue to continue to basically fund our work. And we believe contributed revenue, so we're thinking like foundations, big bet philanthropy, healthcare funders, foundations, high net worth individuals. Those are folks who can really contribute towards research and development and in the innovation side. And so in considering, when being asked to talk about kind of nonprofit business models, I think there's some pretty, the first things I would consider, and things that are just like candidly, like the things that we thought about and are pragmatic to consider, what is the best vehicle for your work? Because I think to some extent, again, we believe that like the 501c3 status is an excellent status for us. It's doing what we need it to do. But you really have to ask yourself a couple questions, and happy to take more questions on that around whether you're considering a not-for-profit model, a for-profit model, a hybrid like B corporation, which is benefit corporation in the United States. A nonprofit is a tax status. It tells you whether you have to pay state or federal taxes. And I think some of it is, where is your primary value? Who needs to trust you for you to succeed? Who are you accountable to, and what level of patience do you require? So kind of taking that down from our perspective, or kind of walking that through from our perspective, like what's going to work for your customers and users. For example, when we were launching, the idea of donation of medicine was still pretty new, and it's still not the like gold standard, right? So it's still something that maybe some people have heard about, maybe some people had not. But in particular, during the time that we were launching, there were a huge amount of pop-up, for example, like in communities, there were pop-ups of like donation bins for clothes and other goods. And in particular, there were a lot of for-profits putting up those bins. And there had started to become like a really interesting, like people were a little bit more, organizations were a little bit more critical and a little bit more like worried, or just a little bit, I think they had a little bit more concern about like, well, where am I, what are you doing with these, what are you doing with these clothes? In that instance, we knew for us that the trust of the medicine donors was going to be very important. There was a lot of skepticism around like, these like for-profit donation bins. And so for us, it actually became really important to gain the trust of the organizations. So it's like pharmacies, nursing homes, et cetera, other types of healthcare facilities who we wanted to donate. Us coming in as a 501c3 nonprofit, as a not-for-profit organization, was extremely important to build trust. It also meant that we weren't coming in the door as like a vendor trying to sell them something. It meant that we were a nonprofit who had a community value proposition that we wanted to share and partner with them. That actually became super important for us very, very early to get in the door of organizations who had the surplus. And so for us, that made a lot of sense, right? And so that was just a very pragmatic piece of some of our decision making. Another key part of the decision is really like, everyone is beholden to someone. So as a nonprofit, like we are incorporated in the state, like our we are accountable to the community, we're accountable to the state, we are accountable to these communities. And so, like we're also accountable to the people who still invest money in us and the impact we want to see. Some of it is, who do you want to be accountable? Like, who are you accountable to and who do you want to be accountable to? And so for us, that made a lot of sense to say, like, we're trying to have community impact. And so, yeah, we should be accountable to the community. Finally, I would say, like, what level of patience do you require? And I don't mean like your individual patients. It's like, is it patient capital or is it more long-term capital? Nonprofit capital is oftentimes difficult to get. It can be slow to get. At the same time, I think that, especially over the past few years, there's been more of a push to say and to recognize that a nonprofit cannot solve a seemingly intractable community problem in a year. It's going to take some time. And so I think, a venture route might make a lot of sense if you're expecting immediate scale or immediate impact. Oftentimes, philanthropic dollars are just harder to get, but you may have more time to work on things, to fine tune the value proposition, to understand what your impact in the community is going to be. And so I think, for us, for example, in early days, we had a lot of like policy things to work through and to understand. And so that takes a while. And so for us being able to say, yep, we were able to utilize those several months to work with the Department of Public Health to figure out this issue, to like make sure this change in regulation actually happened to support the statute. It was really important for us to be able to have somewhat patient capital that would allow us to basically make these steps forward, show a lot of promise, start showing community value and value to the patients that we're serving, but also recognizing that the healthcare system in the United States is not going to be fixed just overnight, and that we needed a little bit more time than the traditional venture-backed model, which is going to look for an exit in a few years. So I want to stop there, because I think I am about at time, and maybe start looking at questions.
That sounds amazing. Thank you so much. Anybody in the room have any questions? If not, I will kick it off. Yeah, Emika.
Yeah, thank you for your presentation. My question would be, at any point in time, do you guys think of giving like tax breaks to institutions who donate these medications to you, like maybe quantifying how much is being donated and then giving tax breaks? Was that like in your game plan or something?
Yes, so that is actually another thing I did not mention, because it's like this is like a very tax, regulatory, all the stuff gets pretty complex, but in the United States, depending on the medicine donor, et cetera, there are tax breaks that organizations can take. And a lot of that is because it's being facilitated by us as a not-for-profit. So that's another advantage of, in particular, us being a nonprofit working in this space, is the ability to help guide organizations through that process and help them try to leverage as much as possible any tax breaks that they could potentially get.
Thank you.
Good. Let me see, Deja, is there any interesting questions online?
That would be good, this one, and then we'll go to the one.
Okay, then go ahead.
Kiah, curious if you just started the company with a nonprofit model in mind. Like, did you walk into this need with, oh, ideally, let's try to do this as a nonprofit, if it makes sense, or is it something that you organically realized would fit retrospectively?
So interestingly, I was pretty agnostic. And we actually did, and this was way back, we actually did, one of our earliest funders who actually funded both nonprofits and for-profits, B Corps, all these other models, actually had us do this workshop, a facilitated workshop, to help us figure out what is the best model. Again, what is the best tax strategy? What is the best model for us to do the work that we wanted to see happen? And so I was like decently agnostic. I knew that I wanted us that for me, working at an impact first organization was quite important, but there are other ways of doing that aren't just being a 501c3 status. I think what really came out of that early workshop was the trust factor of the medicine donors. And so that's in healthcare in the United States, because it's such a big business, right? Like healthcare is like 17% GDP of this country. everyone is in healthcare is being sold something 20 times a day. So like the amount of inbound that they're getting of people trying to sell them something is just overwhelming. The trust factor that we were able to build and the fact that I wasn't coming through the door marked vendor, potential vendor trying to sell us something meant that we were able to get especially early organizations onboarded quicker. So it was slower on the capital side for sure. I think it really helps speed up our ability to partner with organizations. Insofar as like, I'll give another example is like some of the organizations, they were so passionate about the work that we were doing that if they had a conference, they didn't just put us as a table vendor. They actually would let us set up like next to registration and say like, hey, this is the group that we're working with that helps with medicine donation. Like you don't get that as a vendor and you wouldn't get that as a for-profit in that setting, but because we were not for profit, they were able to basically position us more as a partner rather than a vendor. So I didn't really care what our status was. I cared about us being able to do the work. But it is pretty important to think about like, who are the constituents and do they care what business model you have? Then of course we can also talk about, there are also hybrid models where you can do for-profit, nonprofit organizations who have, shared boards. Like there's a lot of different structures you can do behind the scenes if you actually feel like what you want to do is actually something more of a hybrid model, or maybe the nonprofit is doing some amount of actual operations, but a for-profit is owning the technology or, vice versa.
Thank you. I have a lot of questions. So Kiah, I'm going to read the first two and you tell me if you want to answer them separately. Just some basics. What kind of medications get donated? And how do you manage quality control to donations with expired or sub-quality medications?
Yep. So what's really nice, so there's two types of surplus that exist in the US. One is at the very top of the, kind of you think about manufacturing, then wholesaling, then down to like hospitals, pharmacies, et cetera. The first type is someone has over forecasted demand. Like at a manufacturer or wholesaler level, they're like, we're going to sell X amount this year. They put in a healthy safety stock and they still miss that sales target. What ends up happening there is like you end up with a lot of one drug. The second reason there's surplus is actually a patient level event. And that's a little bit more our bread and butter. So this is kind of someone's at a hospital or a nursing home and they had a heart attack. They're on a blood pressure medication and they're getting better. So they're titrated off. So now there's a little bit of surplus of a medication that was actually prescribed at a patient level. That ends up being a little bit of a lot of different drugs. So the product mix is quite broad. So for us at SIRUM, what we see is basically about an 80% match against the 300 most prescribed drugs in the US. So this is like diabetes, hypertension, hyperlipidemia, mental health. It's like all of the kind of normal medications that you see versus oftentimes, and we still do surplus at a higher manufacturer level, et cetera, but that tends to be like kind of a sprinkling. It's like a lot of one drug, pallets of one drug versus a little bit of a lot of drugs shipped across hundreds or thousands of boxes. In terms of quality control, at every recipient organization, it's examined by either a pharmacist or doctor or medical provider. And so that's how it's the quality control. Also, again, it's unexpired. It's also sealed. So interesting. I know we have a very global group here. Like the US is one of the few countries that takes medicine from a big bottle and puts it into a small bottle. Most of the rest of the world, and actually in some healthcare settings in the US, we blister pack the meds, meaning every pill's in its own little sealed packaging. So the vast majority of the medicine that we get is actually individual dose sealed like that. So it even has like all the labeling, et cetera, and it's in tamper evident packaging.
We have a lot of questions about the 3 states you're currently serving now. And then do you do any international or do you partner with other groups to do international? Yeah. Can you speak to that, please?
Yeah, so we actually operate SIRUM. Sorry, that was probably a little confusing. SIRUM itself is doing some amount of distribution to about 47 states. So we're missing, I believe, Alaska, Hawaii, very expensive shipping, and Oregon. But the 3 states I mentioned, that is for our vertically integrated pharmacy. So the US is like our healthcare system is quite complex, similar to like if you're a doctor in one state, you're only a doctor in that state. And if you want to go practice medicine in another state, you got to go get re-credentialed and re-licensed in that state, and sometimes even sit for an exam. Similar in pharmacy, like our pharmacy is based in Georgia and is licensed to ship to Illinois and Maryland. And what we're doing is working towards getting more and more licenses so that eventually that pharmacy could ship more broadly in the US. In terms of international, we actually looked at this really early on. Like, could we ship medications internationally? What would that look like? And our very fancy, I'll say one other advantage of being a nonprofit in this instance for us was pro bono attorneys. I think probably nonprofits don't take as much advantage as they could of literally firms that charge thousands of dollars per hour in legal consult, but you can be a pro bono client. Our very, very amazing pro bono lawyers basically went really deep down this, and it's not impossible, but generally speaking, to get the same level of protection, because the US is a very litigious country, you would need some sort of like treaty between the two countries that basically says, you won't sue us and we won't sue you. So that's what it will require. And in the US in particular, the reason organizations are willing to donate is because there is Good Samaritan laws put in place that says they can donate and not get sued. Otherwise, in the US, everyone is constantly afraid of getting sued because everyone gets sued for everything all the time. And so it's not impossible to go international. It's just quite hard because you have to have mutuality in how you deal with like each other's laws.
Thanks. You were speaking about registering in different states. Could you elaborate on types of regulations you face both at federal and state level? And well, let's just start there.
Yeah, so I'll give one big federal one is we don't do any controlled substances because that is, so no like oxy or anything like that, because that is actually regulated at a federal level and would be very difficult, and we do not want to contribute towards the opioid crisis that exists in this country. At a state level, though, it's a patchwork of state laws of who can donate, like what institutions or individuals can donate, what can be donated. Like certain states allow things that are temperature controlled to be donated, as long as you obviously like control the temperature throughout the entire donation process. And some say flat out no. Some have a listed date of expiration, like some will actually say it must be 90 days from expiration. Some just say it has to be unexpired. So there's a ton of patchwork state laws around like who can donate, what can donate, where can it be donated to. And a lot of what we do is basically managing that work to make sure you're not a healthcare facility in Minnesota and try to donate something into another state that you're not eligible to donate to because you don't have ABC or XYZ license. It's quite complex. Like we've actually done more policy work than we originally thought we would, and actually drafted a model legislation to catch things like that. And to say like, hey, states, if you want to do this work, you absolutely should. Here are our lessons learned of like how to make your state law not more work. I'll give a for example. There was a state in the Southwest who I think I intentionally do not remember the name of the state. The way they wrote the law was for every donated item, you have to have a piece of paper that's signed by the medicine donor and recipient. And so what that ended up being, our average donation is like 200 to 400 items in a box. But the way that they actually wrote the law actually said that there must be a separate piece of paper with a wet signature. And so we went to them, we were like, hey, like the average donation is 200 items. I don't think you mean you want 200 pieces of paper where a nurse signs a form 200 times and then a pharmacist or a doctor also signs that same form 200 times. They're like, well, that's how the law was written. There's a lot of things that are like very well intentioned, but like not operationally viable. And so that's another way, like us as a 501c3, like us as a nonprofit, organizations don't necessarily think about this, but you can give expert opinion and testimony at a state level, and you're considered kind of you're an unbiased, like you're an unbiased organization. Like we're just saying this is how I'd write the policy to be inclusive and safe, rather than, you know, you've actually created a policy that requires 200 pieces of paper to go in a box. And you can't even have a manifest. I mean, like the way it was written, it wouldn't even allow like, here's a manifest of drugs and someone sign a top sheet. So I think those are the unintentional things that sometimes happen that on the policy side, we tend to get involved in when organizations and states ask us to say like, how can I make something really scalable work?
On that topic of the patchwork, how do you advise researching and learning about all the myriads of regulations when you're building a company or trying to develop a solution?
I think that it's interesting, a liberal arts education, who'da thunk? Some of those are even like, you know, I remember like old school SAT stuff that was like, these paragraphs are incredibly boring and very, very difficult to read, but your job is actually to read and come to a complete comprehensive understanding. That is policy work, in fact, in the kind of like, in it, does it say shall? Does it say may? Like, must you do this thing or can you do this thing? That actually becomes quite important. I think a lot of it is, I mean, nowadays, what's really nice is you could probably throw this into AI, like basically pull down statute and regs that are PS in many, many municipalities still in PDFs, not, you know, inline text. You probably throw this into AI and at least ask it some questions. But a lot of the policy work, et cetera, is really digging into the details of laws and regulations, but then actually having conversation, because how it's practiced on the ground with healthcare providers is oftentimes a little bit different. And understanding how people comply with things or what their interpretation is pretty important.
And you mentioned that you had written a policy paper. Is that something you could share your learnings with all of us too? Is there a link we can follow up with later?
Yeah, we can actually share. There's the National Conference of State Legislature has a page specifically devoted to this issue. And we've actually we kind of have done a lot of the research on like what states are active, which ones are not, just to help with the ecosystem. I can share a link for that.
That'd be awesome. Thank you. Time for more questions? Great. Is there a max development cost or time to sales that patient capital is able to withstand? And thinking about med device and pharma firms, often for profit due to cost and timeline before revenue?
Yeah, that's a great question. And I think like this is candidly like how, like, yeah, I could have a very long conversation around one of the big challenges, especially in like pharma in the US related to that topic alone. I think for us, we would not be here if we started out just trying to launch a pharmacy, because no one would have given us the capital in order to do brick and mortar and the CapEx required for some of the automation work that we needed. It was actually only possible because we had a strong enough track record building the SaaS that we did for the time that we did it. And so there is definitely, I think, a challenge. Like the advantage, I think, of doing a more traditional venture-backed or investor-backed play when it comes to healthcare, knowing that there's all of the regulatory stuff that still exists. At least you'll know, like, it's going to work or it's not going to work, and you're either going to meet that timeline or not. I think to some extent, the hard thing about being a not-for-profit is, do you just say, I'm going to keep fundraising and keep fundraising and keep cutting costs and keep things lean, and then like just keep going based on willpower alone? Like there's a little bit more maybe an ability to have to take that as a tact. But I think it's a super fair question. I think for us, it was, we were still able to have patient impact because our first thesis was software as service. And it was only when we realized that we actually capped out scale that then we were able to make a decent case. But still, candidly, our first brick and mortar, we used prize money. Like we had to use prize money we won in a competition to launch that because we couldn't get any solid grant funding to support like this idea. I'm going to age myself at this by saying this, but it was kind of like a field of dreams. Like, if you build it, they will come. I did a whole roadshow of like, we have done all these things. We're pretty sure we can build it. Like, help us. And we ended up using a lot of prize money, like unrestricted dollars, to basically launch our first foray. So I don't think like, I think that is I think that some of things have changed in that there are more funders now on the nonprofit side, probably because things have gotten so much harder, and probably because the difference between people who have and have not, like that has grown so much wider. I think that there is more risk capital available in the social sector and in the not-for-profit space than there was 10 years ago.
And this is a bit of a follow-on, and maybe just elaborating on what you were just saying, is what objections, if you're willing to share, did funders, you don't have to name any names, have to SIRUM originally? And what did you do to address them? And I think, you know, with the spirit of future entrepreneurs here learning from your path.
Yeah, I mean, I'll be super candid on the original SIRUM funding. Like, who is going to give these people? Like, people were like, "Oh, are you a doctor? Are you a pharmacist?" No, but trust me, give us some funding and make this happen. I think a lot of it for us was it ended up being a lot of relationships, and I think this is the vastly unfair thing about the world is like things like where you go to school matters. Like probably we got our first, like I don't think it's probably, like almost positively, we got our first money that allowed us to really do it because myself, Adam, and George all went to Stanford, and we had a network, and that network enabled us to actually get enough, scrape enough money together to quit our jobs and start. So I think that's like very unfair. But it was like social capital that allowed us to get there. The fact that we could troll an alumni database and start sending emails to people who had resources. I think without that, there are again the social impact, and I think especially if you're looking to do something tech for good, that whole space, there is an ecosystem now for organizations who and individuals who want to do more of that work. Like there are the Echoing Greens of the world, who's like an OG social entrepreneurial funder. There's also Fast Forward based in San Francisco, which is a nonprofit tech incubator that they give money to organizations who want to build tech for good. Like I think there's more of an infrastructure now. And then like, yeah, so the reasons people said no was like, you've never done this. No one has ever done this. This seems risky. Early on, like one of the big things we wanted to just be fiscally sponsored, for example, because the paperwork of setting up a, you know, C Corp or S Corp is for the state of California, then having to apply to 501c3 status. Like there's a lot of paperwork that you have to do to incorporate, especially as a nonprofit. There's like added layers to that. So for example, in our first, you know, kind of giddy up, we were like, let's just go be fiscally sponsored by other organizations. We got rejected because all their legal said this was too risky. They're like, we don't think it's worth it. It's risky. So we actually had to incorporate, get pro bono attorneys, all the stuff to like help us do all of this because no one would take us on because of that. So I think those are some of the early things, which is like, no one's ever done this. Healthcare super regulated. No. Those were some of our initial big no's was, yeah, no one's ever done this. Healthcare's hard. And we were like, yes. I mean, to some extent, it's a great moating, right? Like healthcare is incredibly hard to work in, but also it's like if you figure something else, you basically like, you know, you're not going to get a bunch of Me Too's cropping up because it's so hard to do some of the regulatory work.
Yeah, I have a question. Have you seen examples of organizations that have chosen the non-for-profit route where they very obviously should have gone for-profit or vice versa? Because you spoke about that workshop being a pivotal resource in helping you formulate your decision. And I'm just wondering for other entrepreneurs who don't have workshop or resources like that, who maybe choose a path unconsciously and realize it's the wrong path. Like, how do they backtrack and start again? I'm just curious if you've seen examples.
Well, I think the biggest and interesting example here is OpenAI. You can read the internets for things about that. But I think that, yeah, I've seen nonprofits convert to for-profit. I've seen most for-profits, I think the challenge is if they're venture backed, like they're probably just going to go kaput. But I have seen nonprofits actually launch or realize that there was something that was best suited for venture backed. Or I've even seen some organizations do like family office backed, if that makes sense. Like I've seen some organizations who maybe started as a not-for-profit. They were raising money from foundations, from high net worth individuals who maybe have foundations, venture, and family office, then maybe went the route of like, there are these other, and this is like super niche, but if there are family offices who are maybe looking at, hey, I can give you a loan at X percent, like 6%, 8%, et cetera, because you have something that's really working. It's not a venture backed unicorn situation, but it's something that's socially impactful, is making some money, and it should exist. I've seen some organizations go that route, decently successful when they just like need additional capital. So I do think like there are ways of taking that structure, whatever structure you have, and morphing it, especially if to some extent how you're raising money, it might be different arms of the same ultimate organization or decision makers.
Great.
Yeah, we have a few questions here about policy, which it sounds like has been a big part of your work. Could you talk a little bit too, like, for example, were you anticipating it when you came in? How did you leverage the policy regulation climate in the early stage? And then how do you stay on top of it? Like, do you have a dedicated person who does it, or is that you? Can you talk a little bit more about, how SIRUM's been managing that?
Yeah, I came in pretty we knew that about 40 states had drug donation laws on their books. So we're like, great, it's already there. Let's go. I think what we were probably, I'll just speak for me. I was probably just like, honestly, naive to understand just because a policy exists doesn't mean anyone knows about it. It doesn't mean even, in fact, the state agency knows about it. That's supposed to be doing it. And so like, that's just because, especially in a state like California where something like 2,000 laws get passed like every year or every other year, it's like, or every leg session, it's just a lot for anyone to keep up with. And so I'd say for us, I thought we were going to do zero policy because I was like, the reason we were working on SIRUM is because the policy already exists. California was, I think, the 9th state to pass a drug donation law. We were like, great, let's do it. I think what we didn't realize is like, again, as you become an operator and then start operating at scale, policymakers who write legislation, there's a lot of great intention. They don't necessarily know what are the things that are going to impede someone. And so do they know that like, hey, in order to get someone to donate, it needs to be as easy as destruction. If you write a law that makes it a lot harder with 5x the record keeping to donate, is anyone going to do it? No. So I think those are the things that we ended up spending a lot of time like trying to understand and then compare, be like, hey, state X, did you realize that to donate requires 5x more time of a nurse than it is to just chuck it in a box and destroy it? If you want donation to happen, that probably shouldn't be true. So I think for us in early days, it was just communicating with the other thing I'll just say is like legislators are super nice and want to hear, in particular from nonprofits or pretty much any local constituents that are doing good, especially if they've had a hand in helping you do good. So it turns out when we went to, state legislators and say, hey, we're actually utilizing this law that you helped pass, they were like, that's awesome. Tell me more. And then eventually the tell me more and just sending them almost investor updates or stakeholder updates could become like, hey, you know what would help us even more is if what would be allowed to happen is XYZ. So I think there's a natural way of having those conversations as you're proving that you're doing good. In terms of structure, I did not think we would do a lot of policy stuff. Turns out we ended up becoming the national expert on drug. There's like a tiny piece of policy that in most states that we are the expert on, because candidly, we're the only ones who are working at this on scale. And are looking state by state to look at parity or lack of parity across states. So we have a tiny policy shop internally that we either get connected or we see like, states will put like RFP or like, hey, we're making rules for this, and we'll engage when states are interested in engagement and having that conversation.
Well, thank you so much, Kiah, and thank you to all of you who joined online. Just as we close today up, we've never actually had a conversation at Biodesign about what are the different types of models, because there's always been an assumption that it will 100% be a for-profit venture-backed model, and that definitely works for some needs, but not all needs. And as many of you in the room know, who are dealing with different types of needs, where you're trying to grapple with stakeholders who maybe don't work in that model, or a type of funding which won't be 10 years, everything will be exited. I think here you provided a lot of inspiration and just some food for thought to how we can rethink what happens when you have found a really great need, when you validated it, when you found a winning solution, but when the thinking that this has to be venture and this has to be for profit just doesn't fit, what do you do then? And what I really loved, particularly in the last bit that you shared, is that you didn't just think, oh, well, it's a policy problem. You've actually built the policy team into your stakeholders, your champions. And I think many of the needs that I'm seeing now in our fellows group, we actually have non-conventional stakeholders. And I encourage you all to think about, like, how do you not just see them as a stakeholder that you're going to approach in the same way that you approach all your traditional stakeholders, but how do you form really interesting relationships to form win-win synergies to build something new? And we will be exploring more in the webinars to come, how do we really ensure the types of capital that are congruent with these types of models? And how do we become more and more creative about nonprofit models that can endure whatever administration is in place, whatever funding landscape is in place, and ultimately be sustainable? So thank you for being the light in that and being such an incredible example of the hard work you do. And yeah, I think all of us have really encouraged and inspired. For those of you joining online, I saw there was 43 of you at one point, which is amazing. We're so grateful for your attendance and especially all your questions today. Thank you so much for engaging. We have these webinars every month. And so we have one coming in February, March, and April. We will share those shortly on our social media. And the recording of this will be posted to our YouTube channel. So for those of you in the room, please can we give Kiah a huge round of applause. And then for those of you online, feel free to, you're going to see a QR code in just a moment where you can scan to sign up to the Bay Area Global Health Alliance newsletter, which is one of our partners. And then please do check us out on YouTube. Kiah, thank you for your time. We're going to end the webinar now. And thank you.
Thanks, everyone.